Universal healthcare systems operate on a noble promise to save lives, but many are currently engineered for financial failure. When a system is designed strictly to treat illness after it appears, it creates a mathematical debt that eventually comes due. Aruba's Allgemeine Ziektekostenversicherung becomes ill, at which point it releases the capital necessary for treatment. This approach processes acute medical emergencies with high efficiency. If a patient requires immediate surgery or trauma care, the curative model responds effectively. However, it lacks the sensors required to detect the gradual accumulation of long-term health risks. A healthcare system that waits for a crisis to initiate care is sustainable only if medical needs remain brief and episodic. When the primary threats to a population change, this reactive posture becomes a structural liability. An aging demographic and non-communicable diseases like diabetes are dismantling the curative model. These chronic conditions require lifelong management, not a single fix. As they proliferate, they push the cost curve exponential, far exceeding AZV's budgetary projections. Ensuring the survival of universal coverage requires a total pivot. The system must transition from a model of late-stage treatment to one of comprehensive, continuous preventive care. This transition involves a systemic overhaul. To be effective, the shift must be hard-coded into the clinical, financial, and legal foundations of the system. The modern demographic landscape has rendered the old model obsolete. Lasting population health can no longer be achieved simply by managing the symptoms of an existing crisis. The first stage of this rebuild focuses on the clinical foundation. This base currently supports general practitioners, hospital services, and prescription medications, the essentials of curative care. But there are gaps in this foundation. Routine health examinations, preventive dental work, routine vision screenings, and mental health counseling are often treated as secondary, despite their role in stopping chronic disease early. Under the proposed reform, these services integrate into the core AZV mandate. By covering checkups and screening as standard benefits, the system intervenes much earlier in life. This forces a change in how primary care operates. Family doctors move from being gatekeepers who provide referrals to specialists to becoming active hubs for early diagnostic intervention and lifestyle management. Broadening the clinical scope is a necessary first step, but expanding services without a new economic model to support them would only accelerate the rise in national healthcare spending. The economic challenge is clear. Preventive care requires a significant upfront investment in screenings and vaccinations. Traditional funding methods struggle to support this spike in initial activity. The standard fee-for-service model creates a conflict of interest, as it financially rewards providers when patients are sick and require more procedures. This model offers no incentive for keeping a population healthy. To solve this, the reform introduces two new funding mechanisms. The first is a capitation model, where providers receive a set fee per patient. This turns health into a profit center. The doctor maximizes resources by keeping the patient well and out of the hospital. Performance-based reimbursements complement this. Providers receive bonuses based on their success in meeting population benchmarks, such as high vaccination rates or early detection of hypertension. This creates a sustainable cycle. Low-cost interventions prevent expensive hospitalizations. The system captures these savings and reinvests them into a dedicated fund for further preventative services. By aligning the financial incentives with health outcomes, the AZV can transform from a reactive payer into a system that generates capital through the successful prevention of disease. For these clinical and financial shifts to last, they must be more than just policy suggestions. Without a framework to enforce them, the system will eventually drift back toward reactive care. This requires formal amendments to the AZV Act, mandating preventative services as non-negotiable benefits. At a national scale, new data protection laws must safeguard privacy, while allowing the large-scale analysis needed to track system effectiveness. This data feeds into a monitoring and evaluation framework. This system acts as a continuous audit of the entire preventative program. The framework establishes quantitative baselines, measuring everything from the percentage of the population screened for cancer to the success rates of lifestyle counseling programs. This creates a direct, actionable feedback loop. If the data shows an intervention is failing to improve health or save costs, the system can legally reallocate those resources to more effective strategies. The integration of legal mandates and rigorous evaluation transforms theoretical healthcare ideas into a measurable and enforceable public policy. However, even the best laws cannot overcome the sheer volume of information. Processing a nation's real-time health data is too complex for manual analysis. To manage this complexity, the system integrates artificial intelligence. This technology processes data at a scale and speed that allows the preventive model to function effectively across the whole population. Predictive analytics allows the system to look forward, scanning data to identify high-risk individuals before symptoms appear. AI also accelerates diagnostics. In radiology, computer vision detects microscopic anomalies faster than manual review, catching diseases in their earliest stages. At the national level, AI provides macro surveillance. By monitoring health trends in real time, it can predict disease outbreaks or identify emerging public health crises, allowing the AZV to mobilize resources before a situation escalates. Integrating this technology allows the healthcare system to stop reacting to the present and begin mathematically anticipating the future health needs of the population. This integrated framework represents a complete redesign of the AZV. Each layer, clinical, financial, legal, and technological, now works in unison. We can see this in action through a single routine screening. When a patient's data is collected at the clinical level, it is verified and anonymized as it moves through the legal and financial layers. The AI layer analyzes the risk. If it identifies a high probability of a future chronic condition, it immediately generates a proactive care plan tailored to that individual. This signal reallocates the necessary funding to the provider and alerts the primary care team to begin treatment. The entire process happens automatically, driven by data rather than a medical crisis. In a modern national system, preventive care functions as an automated economic engine. It identifies and neutralizes health threats long before they become a burden on the individual patient or the national taxpayer. By committing to this systemic rebuild, universal healthcare transforms. It is no longer just a way to pay for treatment. It is a proactive and sustainable guardian of a nation's health.